housing stability is not binary. It's not you're unhoused and now you're going to be housed. It's you're unhoused. You're probably unhoused for a number of reasons. What are those reasons and how are we solving for those in order to get you on a path towards stability and long-term stability?
We usually think of housing and healthcare as two separate industries, but providing housing stability can actually improve health outcomes. In this episode of the AgeTech Podcast, Jake Rothstein, CEO and founder of Upside, breaks down how they built a network that gets health payers to invest in housing stability without laying a single brick. Jake, welcome to the show.
Thank you. Thank you for having me back.
So this is the second time you've been on the show. I think the first time was during COVID, so quite a long time ago, and a lot has
Wow.
changed.
Indeed, I can't believe it's been that long. Wow, that's crazy.
It has. So could you give us a recap of sort of the arc, the story arc of Upside from 5 years ago until today?
Yeah, totally. It's a long story, so I'll shorten it for for listeners' perspectives. We started based on a personal need, right? My grandmother found herself alone at the age of 87 after having cared for my grandfather for a long time with Alzheimer's. She wound up moving him to assisted living, to memory care specifically, and found herself at 87 in this two-story house that she could no longer maintain or afford or navigate. She couldn't walk up and down the stairs. She had recently had knee replacement surgery. And so the impetus for Upside came from helping her. The family got together and we said, okay, well, she can no longer stay in this house. It's not sustainable. She has equity in it. So let's sell the house. Let's take the equity. Let's move her to a rental apartment. And I'll step in as the grandson that's, the closest by and help her out with the things that grandmothers need help with, transportation and groceries and shop, doctor's appointments and things like that. And that's what we started Upside on, that premise. We said, we're going to build the biggest senior living community in the world without laying a single brick. And we're going to do that by utilizing existing apartment infrastructure, vetting it to ensure quality and accessibility and affordability for older adults specifically. We'll create these great intergenerational communities because, these buildings are inherently intergenerational. And, eventually we'll work towards finding distribution through payers. And that's what we had done at Papa, and that's what the intention was with Upside. And so we started that like that, and we started placing older adults really all across the country in communities and apartments that were vetted by us. And so we started conglomerating this network of vetted apartments, right? And a couple of years into it, I think sooner than we anticipated, we started kind of loosely talking to payers, Medicare Advantage specifically. And Medicare Advantage organizations and leaders started telling us, like, well, this is an incredible concept. And if you can build this national network of apartments, you can create housing stability programs and all this stuff. But it was weird. It was weird timing. It was 2023, and there was a major pullback in supplemental benefits, which was the payment mechanism that we were going to utilize to support the program, specifically as it related to Medicare Advantage. And one thing led to another, and we wound up talking to a lot of Medicaid managed care organizations. And so when you're talking to these big payers, right, they have managed care Medicaid, they have Medicare Advantage organizations, they have commercial lines of business. So we hadn't, at the time in 2023, hadn't had any real experience with vulnerable, lower income folks, Medicaid population. But we said, we're willing to try and see if we can use this kind of systematic way of understanding the real-time pricing and floor plan and unit mix of all these apartments that are in our community and vetted as it relates to the populations that we serve. And so we had a conversation with one big national payer, and they had a state in Virginia, they had a health plan in Virginia where they said, well, we've got really challenging populations, specifically in these 3 counties in this state, and we can find you some money and, we can maybe put a pilot together. And so in January of 2024, we launched our first payer pilot with a Medicaid managed care organization in Virginia. And within 3 months, using this network of apartments that we had curated and vetted and sort of tailored to this Medicaid population that we knew we were going to be serving, we started stabilizing people, housing stabilizing them within a 3-month period at rates that the health plan had never seen before. And in doing so, we had convinced, kind of along this journey, we had convinced the health plans that it made sense for them to help get these members into stabilized settings and to pay for that because there was a clear and tangible ROI associated with it. And the way that translates is to reduction in hospitalizations and reduction to fall risk and reduction to emergency department visits and hospitalization length of stays and medication adherence and all these things that impact medical costs down the road. And so that pilot wound up expanding across now 7 states with one big national payer. We are working with all of the big national payers now over the course of the last 2.5 years. The team has grown by we started the year at 9 people. We're at 45 people. And it's been a wild journey, and we're just getting started.
Wow. So I already knew that housing or housing stability was part of the social determinants of health, but I didn't realize that payers were able to actually measure that. How long did it take you to show ROI?
So the way it works with payers is they need to be able to understand ROI from a theoretical or hypothetical standpoint at the launch of a program. But every payer also wants to understand the ROI as it relates to their specific population, not a sample population, not a population that looks like their population, but their actual population. So that happens kind of over time, and it's continuing to happen with us. But what we did at the onset was we said, okay, well, there's all of these housing studies out there and that articulate and that show meaningful cost savings to the healthcare system, to medical costs, as a result of stabilizing certainly the most vulnerable people, but even those that aren't as vulnerable. And what we found was that housing stability applies and is prevalent in a lot more people than we thought it was. For example, in Medicaid, 40% of members that we interact with have housing instability. We interact with 100%. 40% of Medicaid members are flagged positive for housing instability. Medicare Advantage has almost similar numbers. And what we sort of realized was that the breadth of this problem is much bigger than we thought. And housing stability manifests itself in so many more ways than we thought it was. When we first started in Medicaid, we were under the impression that housing instability is, you're homeless and you're living under a bridge, or you're an addict, or you might have a mental health issue. The reality is that people that are victims of abuse could have housing instability because they can't stay where they're at. Or maybe they're living on their friend's couch for the last 3 years because they've had to move for medical reasons. Or maybe they lost their job and they already got another job, but they don't know where they're going to go in between. And so they're temporarily homeless. And so the amount of reasons that cause housing instability, the triggers for housing instability are very varied, and the list is very long. And it's in the health plan's best interest because they share the risk, or they own the risk, they carry the risk for these patients, to ensure that housing stability, ensure it quickly and for the long term. And so we made that case with very clear and articulate, actuarially backed ROI modeling. And we continue to make the case with identification of members that we help, pulling claims in relation to those members, and understanding over time how our program actually reduces claims.
I have a question that could be provocative, or it could be just ignorant because I'm not American. Doesn't it work better in the payer's interest if the person becomes homeless and then they drop out of being a member?
Not really. So the payer wants to keep the member. The payer wants to keep the member because they get a capitated rate from the federal government. In Medicaid, that's how it works too. And in Medicare Advantage, it works similarly. The Medicare Managed Care Organization receives a payment for that member and for all of their members for every month that they're in the system and they're in their, that they're under their care. And so, these people are typically remaining in Medicaid, or they're remaining in Medicare Advantage, but their medical costs are reduced. And so the idea is, let's go upstream, let's get ahead of claims, because the only time that health plans really, without programs like this, the only time health plans really see problems is through claims. And so they only see a problem after it's already happened. So we go to them and we say, okay, we can survey members for housing instability. You can survey them, whoever you want to survey them. We can understand people that have housing instability and capture rising risk within your population and nip those challenges early on so that you can find out about them before they wind up in your claims box and before you incur major $40,000 hospital admissions for those members. And so it is in very much alignment with the health plan's revenue goals and profit goals to get upstream of so many of these, kind of housing related issues that could potentially arise from housing instability, like I mentioned, fall risk and the avoidance and all this stuff. So that's why we're getting a lot of, so much traction on the program.
That is wonderful. What did you have to change about the product when you expanded your reach from not just Medicare, but to also serve Medicaid?
It's a great question. So the type of housing that might be suitable for an older adult is different than the type of housing that might be suitable for someone that's low income or someone with a disability. And so what we do is we take a very fine-tooth comb and we understand the inventory in our network, and our network spans now across the country, all 50 states and 33,000 apartment communities, plus a variety of different types of housing. We include Section 8 in our inventory. We have group homes in our inventory for people that have special, specific types of circumstances that might require that. And so we've had to add a lot of types of housing that aren't just suitable for older adults, but for all of these people. And especially where it's interesting is where the older adult and the lower income population coincide. These dually eligible members for both Medicare and Medicaid, those are really vulnerable members. They're very high cost to the health plan, and as a result, they're very very hotly interested by the health plan to help stabilize from a housing perspective. So we've been really successful there as well. In terms of the actual physical inventory, for us, the process is very similar. So we're running the same process on understanding and determining what inventory is suitable for an older adult or suitable for a Medicaid recipient. It's just a matter of, filtering out one thing or another dependent on the member's specific needs. And everything's very individualized that we do. And thankfully, we have technology as a backbone of this that allows us to do this really quickly. And so what really is our secret sauce is this proprietary network of inventory that we have real-time visibility into that can provide these most vulnerable members among us access and advocacy to get them housed really quickly. Because if they're walking off the street trying to find an apartment, the kind of the knee-jerk reaction from all of our clients at the very beginning of our interaction with them is, well, there's not enough affordable housing. And what we say is, well, there's also not a efficient utilization of the housing that exists. And the reason there's not an efficient utilization of the housing that exists is because everything's very pigeonholed. Everything's very narrowly focused. The local Section 8 housing authority only sees what's in their purview. The local mom and pop landlord that has a multi-tenant apartment complex, they only see the availability in their purview. The case manager that works at the health plan that's assigned to these members only has the ability to go to apartments.com or Zillow and see what's locally available, if that's even up to date. And who knows if it meets the standards of that Medicaid member that has a low credit score or a criminal background or a mobility challenge. And so there is until us, there is no centralized place to find real-time information on inventory that relates to specific healthcare populations. And that's what we've really done, and that's changed the game.
So how does it work in practice? Are you the landlord and the person is renting from you, and then Medicare pays them, or does Medicare or Medicaid pay you directly?
Medicare and Medicaid pays us directly, and we're not the landlord. We don't actually carry risk on any of the apartments. There's an argument to be made where there's an opportunity for us to do that maybe down the road. But what we said is, let's utilize this existing infrastructure. Let's be the facilitator, the advocates, the eyeballs, the eyes and ears to what's available, and get these people, the most vulnerable people, into the most available housing near them that's affordable, that's sustainable. And let's do that more efficiently and more quickly than anybody else can do it, including the health plans themselves. And so we are kind of that glue that keeps the whole system together, and that allows the most vulnerable members to be housed really quickly. The second part of that, and I think the reason we provide a lot of value to our customers, is the data piece. We track everything. We track everything from the first interaction with our member until the time that they're housed, and then beyond the time that they're housed, to ensure that they stay housed long term, because that's also a really big problem. You can house someone and you might be able to house them temporarily, but the recidivism rates on becoming unhoused again for someone that's housing unstable they're very high. So they need consistent touches. They need consistent interactions, and those interactions need to be appropriate. They need to be timely, and they need to be relevant to the member that we're serving. And so we can do that, and we can provide the data back to the health plan that says, okay, here's the justification for this program. Here's the reason. Here's the kind of real-time ROI that you're experiencing as a result of this missed ER visit or this primary care visit that happened as a result of our engagement with them. And so that data layer is a really important element of all of this that sits on top of the actual housing infrastructure.
Is retention a big part of the incentive for Medicare Advantage, at least, to work with you? Because if someone is on a specific Medicare Advantage plan and they have their housing paid for, and then maybe if they switch to another plan, they don't work with you, so they have to find another.
Yeah, I'll clarify one point. Medicare's not paying for the rent. They're paying for everything that's ancillary to rent. In some cases, in Medicaid specifically, we utilize what they call flex fund dollars. And flex fund dollars are dollars that sit at the health plan level, at the state level, at the health plan, that are to be used or allowed to be used on things that are ancillary to rent, things like security deposit assistance, things like rental payments and arrears, things like utility assistance. What we learned doing this is that so many of the barriers to stability for vulnerable members and for vulnerable people are those security deposits, right? Like I can afford the rent. I can afford to make rent because my job, I barely can make it, but I don't have any money saved for a security deposit. I need $2,000. And the health plan historically has not been good at distributing those dollars. They don't want to give it to the member themselves because there's, trust issues there. And they don't have the relationships with the landlords that we do. So we become the fiduciary, the intermediary for those flex fund dollars to the landlords themselves. And as a result of that, we unlock so many people from instability to stability by facilitating those transactions and efficiently utilize those dollars that are just sitting on the sidelines, either unutilized or underutilized today. And so it's a really important, element of our success. And we see that applied throughout. You mentioned retention. Retention is incredibly important. Acquisition is important on Medicare Advantage from a marketability standpoint, using this program as a marketable asset for older adults that specifically know they're coming into a period of their life where they might have to downsize or they might have to look for an assisted living facility or some sort of senior living facility. Those are really important selling points. But like you said, once they have the help with something that's so important as housing from, an entity that's associated with their health plan, stars ratings go up, HEDIS scores go up on the Medicaid side, retention increases as long as we're keeping them in the population, in the, the plan area and the coverage area, which most of the time happens because we work to make that happen. Yeah, all those things are a factor.
That is brilliant. So what happens when someone sort of grows older? They've been on Medicaid and now they're older and they're dually eligible. Do they sort of check with you before they transition into Medicare to see whether Medicare works with you so they can stay in their current housing?
Typically, because the member is paying the rent themselves, there typically isn't an issue with that. So if they're transitioning from straight Medicaid to coming into dual eligible, their benefits only increase and they're able to stay where they're located. So that's typically not an issue. Where we do see interesting kind of transitions and where we help with this is the transition from acute long-term, from a skilled nursing, from an acute type of injury or recovery back to independent or more independent living situations. We work with a big national payer in Florida on a transition from long-term care program. And essentially what that means is they have a population of older adults predominantly that lives or has lived in a skilled nursing, a SNF facility for 6 months or more. And as you know, those skilled nursing facilities are incredibly expensive to the system. It could be $3,000 a day for a very high level of care. And in many cases, those members are ready and able and willing to transition out of those places, but they have nowhere to go. And they need an advocate and they need someone to help them. And their daughter lives in another country or their son lives, they don't have kids. And so we work with those members to transition them out of skilled nursing into independent living or assisted living or even an apartment that they can manage on their own. And we do that with really high levels of success. And the reason is because not only do we have this network on the backbone and the back end, but we have the support of the payer. We have the support of the health plan to say, hey, do you need transportation assistance to actually go on tours? Or do you need non-medical emergency transport to get you from this SNF to to this facility? So there's all of these nuances that payers can be so helpful with, but they can't do it alone. They need to remove the housing or extract the housing components, the complexities of it, out of their traditional case management kind of workflow in order to make everyone more efficient. Their case managers become more efficient because now they're just dealing with the behavioral health issues or the rehab issues or whatever it is. And we focus on the housing issues. Everyone works as a team together and can get things done a lot more efficiently and effectively and quickly.
Fascinating. So I want to talk a little bit about the technology in the back end. I bet you have lots of AI in the back end, like everyone these days. Can you share a bit about sort of how that has helped you grow or become more efficient or, I don't know, produce better, more engaging user interfaces for users?
Sure. So AI is everywhere. If you're not using AI, you're probably not in business in 2025. So that is the common theme. And the second common theme in healthcare specifically is you really need humans in the mix. And humans in the mix is a very important thing, specifically as it relates to very vulnerable populations like in Medicare or Medicaid. And so what we've done is we've put humans at the tip of the spear. We've said, okay, Someone needs a helping hand, a shoulder to cry on when they're in a time of crisis or near crisis as it relates to their housing situation, one of the most important things to their health. Humans engage and lead the relationship component of the interaction with that and the engagement with that member. AI handles the things that humans don't want to do or aren't really good or efficient at doing. The administrative tasks, the algorithm matching the best of our inventory with the information from that member based on the intake call that we have with them. We're listening to intake calls. We understand what's going on. We extract the data from those intake calls so that we're automatically in the background searching for the appropriate community and appropriate apartment, the appropriate ancillary services that might support that engagement, so that by the time the care guide gets off the initial call with a member, we already have an idea exactly where they're going to be going and how they're going to get there. And things like the administrative tasks of ensuring that someone is on this journey towards housing instability. I think one of the things that we learned as we've gone through this is it's not housing stability is not binary. It's not you're unhoused and now you're going to be housed. It's you're unhoused. You're probably unhoused for a number of reasons. What are those reasons and how are we solving for those in order to get you on a path towards stability and long-term stability? Because it's one thing, you could put someone in a shelter overnight because it's raining and cold and you have kids and you're hungry and all of these important things. That's okay and that's good and it's important. But what are we doing to get that person full-time stably housed? Is it making sure that they have a job? Is it making sure that they're in a drug rehab program? Is it making sure that they're on disability insurance and if they can't work? There's all of these things that have to happen in the background. That's why we have a team of experts that have knowledge about housing, but they're also social workers guided by, a clinical team to understand what's clinical, what's housing, how to separate the two, and understand how to get people on this journey. So every single person gets a customized and dynamic housing plan after that first call. That housing plan is used, and that's AI, facilitated. That housing plan is used to guide the member towards housing stability if they come in at a point of complete instability. There's people that come to us and they're homeless, and there's people that come to us and they're temporarily unhoused. And those paths are two very different paths. Both lead to terrible outcomes from a medical cost standpoint, but both have very different solutions to get that member stabilized.
That is fascinating. So when last time we spoke, way back when the company was still upside home, you were providing concierge services. Do you still do that or some of that?
So we made the decision to kind of wind down the consumer side of the business in 2020. Once we started seeing real traction on the payer side, we said, well, we want to really focus on this distribution channel. And the reason was because we can make the impact so much bigger and so much faster with massive distribution, and we have. And so as of 2023-ish, we've sort of discontinued or, moonlighted the consumer business and really work, predominant solely with health plans now. We're also moving into, as of about a couple of months ago, moving into the self-insured employer, self-funded employer space. We see really, really big opportunities there to work with, because housing is so fundamental, right? It's fundamental for really people of all walks of life, the most vulnerable, and even the people that aren't as vulnerable that are dealing with affordability challenges now from a housing perspective. Gen Z is saving for their first house. Good luck. It's very hard. Anything that your employer might be able to contribute to or help with as it relates to that journey, getting to your first house is going to be important. So we look at ourselves as kind of core housing support for government healthcare, but also employer-sponsored healthcare and their the employees that are kind of live within that system.
And is medical transportation something that you're sort of assisting people with or considering to assist people with? Because that could also reduce costs for the payers.
Totally. What we found is using housing as a foundational kind of relationship driver with the member, you build trust really quickly. And that trust enables you to do and engage with the member on so many other things that are really, they are tangential to housing. Things like transportation, medical and non-emergency medical, things like nutrition. We find all the time ourselves helping people enroll in SNAP benefits because we realize that they're eligible, but they're not enrolled, and they can now take that $300 they were spending on food every month and allocate it towards housing. And now, oh my God, the breadth of housing that you can afford in your local market becomes, the aperture widens as a result of having a little bit more disposable income that you could spend towards it. And so as housing's gotten less and less affordable, it's important to understand the ecosystem that a person lives within and the resources that are available to them, transportation, food, all these other things included, in order to unlock more dollars for housing. And that's what we've been able to do and stabilize a lot of people in the process doing that. Advocacy is such a big portion of this. And again, everyone wants to talk about AI being the advocate. You need a human to be the advocate. AI can do so much of the heavy lifting, but you really still need a human in the loop. And I think that's that's one thing that a lot of people don't understand. A lot of companies don't understand, especially working in this space. You build a really shiny object, a really great tool, and those things can be very powerful. There's no doubt about it. And you really have to be building those things. But humans, people want to shoulder cry on sometimes.
Absolutely, 100%. What happens if someone sort of can't afford their apartment at a certain point in time, and then they lose their job and they can't afford to pay rent anymore?
We step in again. So typically we're interacting and engaging with the member, depending on the type of agreement we have in place with whatever payer we're working with. It's either get them housed and ensure that housing stability short-term, or it's get them housed and ensure that stability long-term. So that means that if something happens in the midst of our engagement with a member, either we'll step right in to help, whether that means finding them another place that is more affordable, whether they don't have a job. Maybe that's helping them with job retraining, finding programs for them to do that. Maybe it's helping unlock other resources that could keep them housed for a while. Maybe it's helping them find a roommate. There's a lot of things that go on in the background that could help, in those types of situations. But typically they're getting re-referred to us, again, through the health plan. The way we typically plug in with health plans is through their case management teams. We educate case managers at a health plan that are assigned to these vulnerable members. We let them understand about teach them about the program and how they should refer members to us. And then we just see referral volume just completely, go off the charts once we launch with a payer, because case managers are looking to offload a lot of this complex, very complex housing work that they're not experts at, and they don't have the resources or the tools to be able to, to execute on efficiently. So it could go either way. Sometimes we're either working with the member in real time and that happens, and then we kind of fill the gaps and help, or the member goes back to the health plan. We're completed with the initial engagement, and they come back around through case management and come back to us, and we get engaged to help again.
And have you had any instances when someone was employed, they could afford a specific apartment in a specific market, and then they retire? They don't have any retirement savings or enough retirement savings, and Social Security, it doesn't cover any apartment in the existing market that they currently live in. Do you help them with relocation?
Totally. We help them with all that stuff. We've seen a lot of cases like this. Typically, we want to get ahead of it, right? If we're moving them and stabilizing them and they're close to retirement, we'll have that conversation. We'll understand what their goals are, what their needs are. Everyone talks about whole person healthcare and really understanding holistically the kind of state of mind of the member. And we live by that. We have conversations with members. We're not reading off a checklist. We're not, there's certain boxes we have to check, and there's certain things we probably have to ask in most cases. But we're having conversations, we're building trust, we're understanding holistically what that person's goals are, what they want to achieve. And so if we can avoid those situations and get ahead of it and understand what that person's retirement goals are, when they're retiring, when they want to transition out of where they're living, typically we can kind of get ahead of that. There's instances where we can't, and we have to deal with it in real time as well, in which case we'll help them relocate, we'll help them find, a more suitable place, we'll help them move closer to family. That happens a lot. My daughter lives on the other side of town, and I'm just too far away from her. In the traffic, it's 50 minutes, and I don't have a car, and I can't drive anymore, and I just can't be that far. And so there's things like that too. What we also work to do is, in the case that there is, tenant-landlord dispute or something that is fixable potentially, we have, a team of experts from a legal standpoint, from a working with older adult standpoint. We have people that are trained to help keep people in place, because the ideal situation is if you can in every way keep someone in place and remove the disruption, do that. But of course, in the event in most cases that we deal with, because many of them are very far gone, people have to move. We have the network to help them move. And inventory, one of the questions we get all the time is well, is supply a real problem? Are you supply constrained at all? And the reality is because we're capitalizing on the turnover of traditional housing infrastructure, supply really isn't an issue for us. We're seeing the real-time availability of any building. So a building might be at 97% occupancy, but at any given moment, there might be 3 or 4 or 5 units available in that building. So it looks like a full building. If you were to walk across the street, it's like, there's no inventory here. The market's at 97% occupancy. But the reality is that people move in, they move out, they move in, they move out, they have life changes. There's always some availability, and we're finding that, we're making it available to the people that need it, and we're putting those two things together.
It sounds like a lot of what you're doing is very high touch. How do you do all of that with a team of 45 people?
A lot of automation. You mentioned technology early on. It's very, very important to, we've had we're a technology company, so we came at this with a technology-driven mindset from the very early start. We knew humans were going to be important in the mix, but we also said if we don't build technology sooner than later to facilitate so much of these sort of ancillary work, so that we call them care guides, the care guides can manage the relationship. They just be the relationship person, build the trust. That's all you should do. Everything else happens in the background. We're not perfectly there yet, but we're getting there. It's a really critical component. And the idea is just to continue to scale our impact without, growing the team to be, this massive case management organization. That's not what we are. We're a technology company first. We have case managers on the team that facilitate these interactions and these engagements, these very high, like you mentioned, high touch engagements with members. But when you think about it, you kind of peel the onion back a little, like, what does it mean to stay engaged with a member? In so many cases, it's automatable, a quick check-in every month. People don't want to be bothered more than that. If they're set, they don't want to be bothered too much more than that. So it's very easy to automate a lot of these things that, don't necessarily need human touch, especially with AI. I mean, this has gotten so much easier in the last few years, and also so much cheaper to build and quicker to build. And so, we've taken advantage of that, and I think it's going to help us scale our impact as we continue to see the demand from the market.
That makes a lot of sense. So what's the big vision? Where do you hope to see upside in 5 or 10 years?
That's a great question. We think about this a lot. Kind of overarching, housing for health, right? Like, what does that mean? It means joining the housing industry, the real estate industry, with the healthcare industry, getting those two ginormous, slow-moving, stodgy, capital-intensive industries to speak the same language, because we don't have a choice. Number one is there's 12,000 people, probably 13,000 people a day turning 65 now. They're putting a tremendous burden on the healthcare system. That means they're causing supply constraints on physicians and clinicians and nurses and caregivers for everybody else that might need that. That includes people on Medicaid. That includes people with disabilities. If we don't go upstream to try and solve some of these core social drivers of health, housing being, or in our argument, the most core and the most complex, if we don't solve for those, nothing else matters. We're not going to be able to tackle all these other things. The system collapses on itself. And so, long-term vision, housing for healthcare, what does that mean? It means working with payers, working with providers, working with health hospital systems, working with employers, touching every life that deals with housing, because either you're housed today or you're going to be housed tomorrow, or you got to be, it touches everybody. And we want to be the go-to housing for health company, and we are very quickly becoming that. And I think that's kind of the trajectory that we see ourselves on.
I'm sold on this vision for sure. So that was actually my last question. Is there anything else that we didn't talk about that you would like to add? Any call to action to people in the audience?
Again, this is something that crosses my mind a lot, to try and get people in the industry thinking and speaking the same language as us. One of the things we say is, like, if we don't do something, who's going to? And I think there's not one solution to fix all of these problems. These are very, very big societal issues that we're facing. And so it really needs to be an all hands on deck type of approach. We can tackle the housing piece of this, but we still need more affordable housing. We still need more, regulatory changes so that we can build more of it, because there's not enough of it. We need to figure out how to tackle the affordability issue at its core, because while making things more efficient is really great, it's still an incremental way of tackling a problem that is a monumental problem. And we think we can be a very big part of the solution, but we're not going to be the only part of the solution. So I think that we need to, as a society, be thinking about where we should be allocating our tax dollars, where should we be allocating our human capital to solve some of the biggest challenges of our time. And I believe I'm more optimistic every day that with AI and with really great people that are mission driven, we can fix these things. These are not insurmountable problems, but they're problems that are achievable. But you got to start. got to take that first step. You got to take the bite out of the elephant, so to speak.
Absolutely, 100%. So, Jake, thank you so much for joining me on the show today. It was an absolute pleasure chatting with you as always. And I wish you lots of success in continuing to build Upside. It sounds like you're doing a lot of positive impact in this world.
Thank you so much. It was so good to be here. Really good catching up with you. And yeah, I'm excited about the future, and I hope we can do this again soon.
We will, for sure. Thank you. If you enjoyed this conversation, there's another video YouTube thinks you might like right here. Until next time, stay humble, stay curious.